Thank you for coming.
Thank you.
Congratulations to the Legends President as well.
Thank you.
My congratulations. Yes, you are spending the time together. Let's talk about your profession. You are a
radiation oncologist, professor
Yes.
in radiation oncology in Nice. I am now in private practice, and I use photobiomodulation for more than 30 years now. From the beginning it was totally empiric, and now it's becoming a very rational treatment, nearly as it is for radiation oncology. That's a wonderful evolution.
Yes, I think you have a lot of experience. Just if you are in the part of oncology with laser, maybe you can talk a little bit about the risks and
Yes.
the application. How
Just,
did it come?
yes, just to say that it's no more laser. From today, world is no more World Association for Laser Therapy. It is World Association for Photobiomodulation Therapy.
Okay.
That is totally different. You know, we are not at all laser with burning tissues and so on. We are low energy laser. And now it's no more laser, it's diodes, it's LEDs, LEDs, and now we speak about light giving an amount of dose, and photobiomodulation is a real effect with three effects: analgesic, anti-inflammatory, and healing effect. That's why I would like everyone to stop speaking about laser, because it's so confusing. Everyone is mixing laser with high energy, low energy.
We think about Star Wars,
Yes,
but
yes.
it's not Star Wars, it's therapy.
So that's why we have to yes, trying to explain everyone. And the new name is very important to change our society. To change the name is the journal too will change to photobiomodulation.
What is the new abbreviation for Volt then?
Volt, stay Volt, but L is
Stays like
yes, but L is photobiomodulation. Just to keep.
As vitally as before.
Yes, it's difficult to change acronym. Okay, so that's today from the General Assembly for today. So my application of photobiomodulation, we spoke about low energy laser at that time, was for mucositis at the beginning with intraoral device, and we evolved to an extraoral device, and it's even more important with extraoral device to have good dosimetry, to know how to go deep inside from the skin to the mouth, and to have the amount of energy we are looking for to have the effect. And that was a long time of works, clinical trials, physics trials, etc., to optimize this type of treatment, both for mucositis and then for dermatitis and several other cancer side effects like trismus, xerostomia, lymphedema. And in this congress, we had a very nice cancer group, very nice cancer session, and tomorrow morning we have a special guideline session with all the speakers and experts and chairmen to initiate those guidelines. Some are evidence-based, real guidelines. For other type of complication, it will just be some technical recommendations, how we should work with photobiomodulation to decrease this type of effect. So it's yes, a new area, a new era for photobiomodulation in cancer therapy.
It's very interesting. You were talking about dosimetry.
Yeah.
I think it's a very good. You are come from X-ray radiation, and so you have a feeling for dosimetry.
Yes, it's of course.
And you know the difference between the yes, what's coming out of the machine, what's going in the skin. There's a huge
difference. And when you speak about 4 joules, if it's from the machine, it's nothing, because less than 10% will arrive to the skin, and less than 0.1% will go to the mucosa inside. So it's a totally different approach we have to do, to say the tissue will have to receive 4 joules on all the surface to have this type of effect. If not, it's totally crazy. And the same for cancer risk. That's the only risk we have to deal with is potential cancer risk. In fact, is it a possibility that this increase in proliferation of normal cells should lead to cancer cells? We have now many data for years, and we had no patient with tumor growth due to PBM. And now we have a long series of patients from many countries, and we do some biological studies, in vitro and in vivo studies, showing that 10 times the dose we give every day is no effect. You should have 25 times the dose to have perhaps an effect of proliferation of cancer cells. So if we stay in our normal dose range, there is no problems. And especially for patients with treatment. For patients without any treatment, if he has a tumor growing, we should not give photobiomodulation on the tumor. But if the patient has chemotherapy or chemoradiation or radiation targeting any treatment, we can give PBM with no problem at all. This risk of cancer proliferation is totally null. That's important message too.
Yeah.
So coming back to dosimetry, I think that's the main duty of WORLD, to homogenize all the parameters for all type of treatments, and there is a huge work in that field, especially because all the different machines have different way to give the light, and it's not a easy work. In radiation oncology, all the machines have exactly the same type of dosimetry, and we can assume we have 2 grays on the tissue every day.
Equivalence.
Yes,
everything
is clear. Here it's difficult to make recommendation when if you make, I want to have 4 joules on the tissue, and the people they have a machine, and what I have to do, it's not 3 minutes. That's nothing. It's just a joke. But so there's we have a long period of work to do. But what is sure is that it is a wonderful technique to use because it's efficient. We have now thousands of patients we treat, and we have thousands of good trials, thousands of bad trials too, and some very important randomized trials showing the effect with no doubt on healing effect, on the regeneration of tissues, both for mucosa, for muscles, skin, and all that. That's a wonderful technique. Brain, of course, myocardial infarction, and so on. So in this congress, we had so many different indications that were presented by so many wonderful experts. I think it was a milestone in this area. I had the chance to organize this meeting. It was a long, we worked on it for 2 years now, and the success is wonderful.
Congratulations, yes. What do you think is the future for BMPs?
It's, I think it's just the beginning. I think now it's brand new. Some people, I saw the press in here, they don't speak about laser now. It is photobiomodulation, so the people say, oh, there's a new thing. We have a new treatment. That's a new. No, it's the same.
No, it's the
but that's perhaps true, because it's a totally new way to use it. I think to use it with dosimetry, and not to say we just do laser. That's no sense. We are giving an amount of energy to a tissue, and we'll have the effect we are looking for. And so I'm quite optimistic, because in all this area we had evidence-based in vitro that was not in vivo, because all of these different parameters. In vitro it was simple to verify. We have 4 joules and you have the effect, and to conduct in vitro was totally crazy. So now we evolve, and I think all the effects we are sure in vitro will be done in vivo, and so it's wonderful time, I think, for this technique. We just have to be very close to the manufacturers to have good machines. For years we come from the machines to the patients, and we use this machine. Now we have to come from the indication, from the patient, and to choose a machine that is doing what we want, and to have control of the dose. Very few are giving the control of the dose to verify we have what we are looking for. Most of the machine, they just say we have 4 joules outside the machine, and for that you put 3 minutes and you have it. So that's a brand new area. So I don't want to be yes, to have some cynicism, not at all. I think we have to be very optimistic, and it's I think really strongly that it's just a beginning for very efficient technique for many indications, and that's why people are so enthusiastic about it, because people who knows their machine and knows their way, finally they know what they are giving, and so the experts are really doing extraordinary jobs. But it was very difficult to export due to the lack of homogeneity and so on. Now we should be able to export it and to make it affordable for every doctors everywhere to use photobiomodulation for routine practice.
To make it easier for the
Easy, yes, and not a magic light,
yes,
but really an amount of energy on the tissue to have analgesic, anti-inflammatory,
yep,
and healing effect. And it's so. If you come to my department, it's now in France we have more than 50 cancer centers with low energy laser or photobiomodulation, mainly for mucositis, but for skin toxicity too. And as I am a leader, we have more than 10 machines in my department, and we have 2 technicians every day treating patients, more than 20 a day, with medical prescription. It is reimbursed because we have medical prescription. We have a very strong attitude of rational treatment for mucositis, dermatitis, and several other complications, both in head and neck area, but also in gynecologic, anal canal, etc., for every inflammation. So it's the only point is to be optimistic, but to continue the work, and to really to finish with the old term of laser treatment and so on. I know you did a wonderful job on your website and so on. That's you were very active to promote photobiomodulation,
we
because yes,
change it PBM.
yes, I think it's good to change and to promote this type of light therapy with dosimetry.
Yes.
I think, yes, perhaps I'm obsessed because I am a radiation oncologist, but please, a little dosimetry is yes, we can do now the same we did some years ago, and it's not so difficult. I think to have just to control the dose and to ask the manufacturer. When he speak about 4 joule, where is 4 joule? Is it at on the device, at the end of the device? You know, we had a very nice meta-analysis on mucositis, and most of the trials were positive for PBM, some were negative, and we came back to all of them, and always there was a problem of technical things. Yes, for example, we had a very famous Brazilian trial for mucositis in children, and they say they gave 4 joule per sequence, and finally it was 0.1 because the applicator was long, and from the machine to the final point of the applicator, it decreased 200 times.
Okay.
So and they didn't know that. So it's sort of these things were very common, and so we have to change. And that was very negative for the extension of this technique, because so many people say finally it doesn't work. Of course, if you don't give the good dose, there's no effect. Even for brain, etc. Perhaps for brain stimulation, perhaps it's not so important to have very accurate dose. The big range of dose is possible, but even that we have to range, but has to be. It can work from 0.5 joules to 5 or 6 or 7 joules, and you have to be inside the range. If you are outside, you will have no effect.
Do we need tissue equivalents like an X-ray?
I think for some indication we have to perhaps to go back and to this type of things. For superficial tissue, it's very easy. Of course, you measure and that's it.
Very easy,
but for in-depth, it's complicated.
If you have to penetrate tissue,
yes.
maybe.
So that's why, for example, for healing effect, you have two
jaws.
Yes, you have 630 to 680 nanometers, and then you have 750 to 830 nanometers. Outside, it is not efficient for healing effect. And of course, infrared is much deeper. So for when we have to use transcutaneous device to go through the skin to mucosa, you use an infrared, not red. Even if red is going inside, but at a low dose.
Low dose, yes.
So we try this one. And inside the infrared, we have to better define the dose inside with dosimeters and so on. Dosimetry is not so difficult to make. If it's accessible, you put a dosimeter on the mucosa, for example, and you verify that after the end of the sequence, you have 4 joules on all the surface, not on 2 points, because that was another bias. Sometimes they say I give 4 joules per centimeter square, but just on 2 or 3 points. That was crazy. Yes, so many things so we have to be optimistic, but we have to be realistic too. That it should be long to implement, but we have some I think some very good studies and very good series of patients from which we can extrapolate. And even now we can do very good treatments, but I think world should be very important to, as a society, to give the good way to perform PBM, to look for good parameters in any situation. It's a big offense.
The practitioners, it's so important to get some to-do lists.
Of course.
And in the past we had no to-do lists. And I think this dosimetry would be the first step. Make manuals.
And those manufacturers, they could tell everything they wanted.
Yes.
It's our experience. We are working with a 40 joule or something, and the more the better.
Yes, that's not true.
So many doctors, they are convinced. Okay, sure, more is better.
No, not in this area.
Not at all.
Not at all. We have to dose rate the same. High dose rate we do not have this effect.
Yeah.
So we have to. So it's a long way, I think, but we can be optimistic. World. After this congress tomorrow, we'll stay all the experts and chairmen to write guidelines, technical guidelines that will be published in the year in the new name, same journal with changing his name. To Photobiomodulation, photomedicine and laser surgery. And I hope it will be followed by most of the people. But we have so many different practitioners. We have, of course, medical doctors, oncologists, physiotherapists, dentists, veterinary. Veterinary are perhaps one of the best because they use it rationally for animals for years, and perhaps most in advance than medical doctors. It's strange.
Yes, he's come from veterinary. Yes.
I think guidelines for veterinary medicine is perhaps much better than we have in medical.
As you know, we have this college for laser phototherapy together, and we are working on this since many years, trying to translate the results from science into the front, to the practitioner's practice. And of course, dosimetry is the main topic. People by a laser first question is how do I do? How many joules? How many joules?
Yes.
How many joules?
Exactly.
And I'm personally, I have worked a lot in veterinary medicine, and this is, in a sense, Wild West. You know, there are people who stick very closely to the recommendations of the world. And we are in favor, of course, and we give it to the practitioners. And there are others who work with a very strong class 4 lasers, with a lot of accidents happening. And because there is no rule, there's no certification, the manufacturers want to sell, you know, and of course they don't know it better, they believe it, and it's Wild West still.
That was very bad for the technique, of course, to be not the leaders, but manufacturers were leaders and were.
They were leaders. They, in the sense of they did do the education, and they are forced by law to do so, to give an introduction, you know, and there was nothing else, and we tried to solve this problem. And,
okay.
Yes, it was a lack of competence, I think, and now we have the guideline. We are happy to get the guideline, and I think to
I hope so.
close
So
the gap.
we have to.
Yeah.
I'll be happy to discuss again, and we have to keep in touch.
Thank you very much.
Thank you.